You just heard that the violation of the superior facet joint is a probably underreported, but a significant, potentially significant problem in spine surgery, especially with instrumental MIS. You've heard that the freehand MIS approach, even when fluoro assisted, can lead up to 41% of the total top screws invading that space. Adding fluoroscopy, depending on the specifics, whether it's open with observation or assisted with mini open, the rate is about 9.5 to 32%, still pretty significant. There are ways to mitigate. OR navigation does decrease this rate down to about 8.3. The standalone interbody does represent one way of eliminating the risk of facet joint violation in its entirety. In addition, it has the advantages of reducing the need for intraoperative monitoring and overall reduced costs compared to the robotics and navigation, which do incur a substantial increased cost for instrumentation and utilization of disposables. And it does not subject the patient to pedicle screws overall. So again, a total mitigation. There are multiple standalone interbody options. We're familiar with most. There is the anterior approach. This has the advantage of giving a very large graft, total access to the entirety of the disc space with excellent anterior columns support and reconstruction. You do not have the ability to really decompress the posterior spine, however, so the decompression itself is an indirect manner. Furthermore, there is a learning curve unless you're really adept at navigating the anterior spine. Having a surgeon, access surgeon, does become important. So there is this learning curve, and subsequently there may be some additional factors that go involved with this. The lateral approach is another fairly recent addition to interbody access. Again, this is laterally access through the lateral aspect, through the psoas in many instances, which in of itself creates some difficulties. Once again, you get a large graft, you have a wide access to the interdiscal space. With proper manipulation, you can get tremendous reduction of sagittal abnormalities and restoring sagittal balance. But once again, the decompression is indirect and the learning curve can be steep. The instrumentation and subsequent to IOM does add additional cost and expertise required. The posterior approach has its advantages. It is direct to the pathology, especially when we're dealing with posteriorly situated decompression or compression, and thereby you get direct decompression. Perhaps the more importantly is familiar to all surgeons. We all approach things posteriorly. We all know, have our special approaches and can adapt accordingly. So this familiarity really mitigates the learning curve substantially, and it really becomes just becoming familiar with the instrumentation itself. The VariLift-LX device is the only FDA-cleared standalone expandable interbody fusion device for the posterior approach. It's intended for standalone use in 1 or 2 contiguous levels in treatment of degenerative disc disease with up to a grade 1 spondylolisthesis, usually of a non-lytic nature, of a degenerative nature. This allows a surgeon to treat each patient with the optimum amount of hardware necessary, and it really promotes maintenance of the healthy muscular and skeletal tissue. Supportive tissues are left pretty much intact, so it tends to avoid further destabilization, but to the point of this evening's talk, absolutely avoids the propensity or possibility of posterior facet joint invasion.